So without further ado, I'd like to welcome our esteemed guests, Katherine Henderson, the immediate past President of the Royal College of Emergency Medicine, Adrian Boyle, the President of the Royal College of Emergency Medicine, and Steve Gourley, the incoming President of the Australasian College of Emergency Medicine, who are here representing themselves at the moment with their own opinions about emergency medicine, where we are and where we're going. There will be an opportunity for you all to ask a question or two as the debate goes on, but we'll start off with a few that we've put together ourselves. Now, before we proceed, any of you who haven't yet registered, if you could see Penny, could you put your hand up? At the lunch break, just to scan the code and get the registration done. That generates the certificates and all the sort of administrative business that is required. All right, without much further ado, I'd like to just ask the first question. As clinicians, where would you like emergency medicine to be in 10 years' time, and what can we do as a group to get there?
Chicken.
Quickly passed on.
Thanks, Will. Look, I'm going to start with ACEM turns 40 this year. So emergency medicine in Australia has been going for 40 years. As far as, in my mind, I think what we've done is we've had our establishment phase, we've had a bit of an adolescence, and now we're getting to this point where we need to have a bit of a rethink about who we are. We've got having a bit of an identity crisis. So who are we? What do we want to be? And where do we want to? How do we make ourselves into that person? So the other interesting thing that's happening at the moment is our population and our technology is also changing rapidly. So if you think about it, when I started medicine, there was one pulse oximeter for the entire theatre complex. We didn't really use pulse oximetry. CTs took like 40 minutes to do a CT head. So we have come a massively long way. In Australia, in the next 5 years, the number of people over the age of 80 will triple. So if you think there's a lot of geriatrics in emergency medicine now, it's only going to get a lot worse. And we're going to have to adapt our way of managing people and treating people, in that, particularly that cohort, in a different way, in a better way. So I think what we're going to see in 10 years' time is a very different looking specialty and a very different looking department than what we're seeing it now. Yeah.
So I think I want to look at this from what a patient would want and what we would want for our relatives. And I would like to work in a system where somebody has a health emergency, they can be attended to promptly and go to the right place straight off, be handed over into an emergency department promptly with no delay, undergo a few core diagnostic tests, and end up probably in an inpatient hospital bed, if required, within about 6 hours, start to finish. And that generates this whole system-wide thinking. But I also think we need to be cognizant of what the whole system does. And, just before Christmas, I gave an interview to a newspaper where I described hospitals as lobster traps. Easy to get into, impossible to get out of. And what we're seeing is this lack of system-wide thinking that's getting patients trapped inside hospitals. Therefore, our hospitals become full, our emergency departments become full, our ambulances then can't offload. So the existential threat to good care, and actually our well-being as emergency physicians, is dealing with the consequences of access and crowding block. So until we start to actually apply big system process thinking to the way we look after our patients, we're not going to make any progress. So we've really got to think about, do we have enough beds? Are we using the beds properly? Is the back door working as efficiently as the front door?
I've got my own. Thank you. So I would be going for a system review as well. I would like to believe that in 10 years' time, the way healthcare is planned and commissioned takes account of population need, recognises what it is that emergency departments and emergency systems offer, and makes sure that that is then provided. So rather than us maybe defining what we want to do or how we view ourselves, there actually be a recognition that you've got to have an emergency care system. You've got to have a system that can get to somebody, so has an adequate pre-hospital care system that can do what the needful there. Hopefully in the community already will have had providers that can prevent somebody needing an emergency, but assuming they do, can get to them, can treat them as needed, and then, if necessary, bring them to an emergency system. And that emergency system, that emergency department, has the respect within healthcare that recognises what it does. The population always want there to be an emergency system, and yet we still are aware that our status within healthcare is maybe not as great as some of the other parts of the specialties. At the moment in the UK, we've got this huge problem that we managed the pandemic through the emergency departments and our critical care colleagues and our acute medical colleagues, etc. Everybody needed us, and now we're into the world of elective backlog, and we're prepared to let the emergency care system get back into trouble. And it seems completely crazy that we do this up and down. We actually need to think about population health. What does the population need in terms of its healthcare? It needs an emergency care system. And I hope that we as emergency medicine practitioners would then be the beneficiaries of that, because it would be clear what it is we need to provide to the population. So there would be some clarity rather than this feeling of sticking plaster solution followed by sticking plaster solution to what's going on in healthcare at the moment.
So, given that we have a room full of emergency medicine practitioners, what can we as individuals do to help you as our leaders advocate and engage and make these aspirations come true?
Okay, so I think we have a unique skill set, and if you look at what's going on with the majority of hospital medicine, we are generating a generation of doctors who know more and more about less and less. Okay, so we are in danger within hospitals generating a lot of people who I would describe as wire-fiddling, stent-inserting ophthalmologists. Now, my dad was saved by one of those guys. He had a TAVI for aortic stenosis, and it has done a lot of good for him. But we do need to have balance in the way that we are generating our workforce. And we are generalists. Sometimes I get accused of saying you're not a specialist, you're a generalist. I'm proud to be a generalist, that I'm prepared to do a bit of everything. Best 15 minutes of every other specialty. You know, we need to respond to that. So we need to keep that broad skill set. We have a huge problem in the UK about general medicine, and I'm sure in Australia general medicine works absolutely perfectly. Everybody wants to do it. But actually, I think we need to regain that ground and say that clinicians have this value to think broadly and think holistically about the needs of their whole patients, not just the flow rate through a stent. So I would encourage you to make sure you keep your skills as broad as possible and as useful as possible.
And keep advocating for patients, because patients don't have just one diagnosis. They don't need one ologist very often. So you keep seeing patients who are falling between different groups of clinicians once they've got beyond us. And you kind of go, well, that holistic view of the patient care, we need to keep advocating for our patients. And actually it tends to be then advocating for our sanity, because you start having to negotiate like the UN between different specialties, and they're all trying not to take the patient. But actually, somebody needs to take the patient, and somebody needs to be prepared to deal with the problem list. And Stephen was saying we're going to have all these over 80-year-olds. They're not going to have single system problems, so they're going to have to start either talking to each other or working out how they have somebody who is the advocate beyond the front door. We can only advocate for so long, but we should definitely be advocating.
Yeah. It's so easy to forget the patient in all of this, isn't it? Especially when you're talking at system levels, people often forget that there is a person sitting at the bottom of all this. I think as people live longer and longer with more and more chronic illness, you're right, the single system operator isn't going to help. So we really need to help advocate with our medical colleagues to really strengthen up the generalist sort of approach in medicine. In rural Australia, the rural generalists are actually beginning to pick up that that space, which I think is really useful. From my point of view, because I live and work in Alice Springs, the rural generalist can be quite a good ally and quite a good group to align with as well, you know, and I think we could go a long way of how we better incorporate and use expertise that is there. I was looking at the College of Obstetrics, and they actually do, I think, some of this quite well, and probably a little bit ahead of what we could do. And that's really bringing them in board as affiliative fellows rather than associate fellows rather than we have the diploma and certificate level, but bringing them into the college a little bit more and making them a recognised part of that team. So we've got a little bit of work to do in that space, but there is actually already some work happening, and there's some hope for the future there. But getting back to a generalist thing, never forgetting the patient that's sitting at the centre of it, is absolutely core to what we do. So the question, what can you do to help us out? Please stay engaged. One of the things that we're seeing in workplaces across, and it's not just medicine, it's the concept of quiet quitting. You know, when things get tough, instead of leaning in, some people just turn up, do the bare minimum, and go home and don't do anything at all. That's the worst possible outcome for all of us, because if we want to change the system we all know is under a lot of pressure. The only way we're going to get in is to actually start leaning into this thing, get involved, keep making a noise to make our patients' care better.
All right, so we've all been victims of the curse of the sod, the single organ doctor, where the patient bounces around. And many times that has defaulted back to the emergency department to deal with it. We've also, as you rightly pointed out, in the pandemic managed, in Australia certainly, a lot of the testing, some of the vaccination, certainly all the dangerous bits, everything that no one else wanted to touch. We also have short stay units, observation units, geriatric outreach programs, etc. What is an emergency physician? What is their scope of practice, and when do we stop doing the jobs that no one else wants?
Okay, so it's a loaded question.
No!
So I think we need to make a distinction between urgent and emergency care. Certainly in the UK, we have a very beleaguered set of GPs. They are under enormous pressure, but at the same time, everybody wants them to do more. And we all, as an emergency medicine, we want them to do more. But I think we need to be cognizant of where they can add value as well. So I think we need to navigate where our line is. But if you make yourself useful, people will follow, the money will follow for that. Now, within the NHS, you can make yourself very useful, and the money that follows never seems to be quite enough. There's always that challenge. But I would say that we've got to make sure that we've got to be positioned where we're going to make the greatest value. Personally, and this isn't college policy, I think we have huge value around observation units and clinical decision units and managing the short stay. Going back to my comments at the beginning around access and exit block, the single biggest thing which helps alleviate access block in a hospital is a short stay unit next to an emergency department. And unfortunately, it's not work anybody particularly wants to do, because you get the patients that nobody else wants. But you shorten their length of stay, and you end up with a place where you can run 10 to 15% of all the emergency admissions better than anyone else.
So I would go back to we need population health decisions being made locally. We need regional decisions about what it is that is required for the population. And so then who's going to provide those services, so that there's some transparency about what we're doing. And it doesn't become individual interest. My concern is that you end up with services that relate to somebody's passion. Now, you always need people with passion, but the risk is that you veer off in one direction and you don't veer off in another. Well, that population doesn't necessarily deserve that range of decisions. It should be being done transparently. And so if we can decide what it is that is needed, we then can decide who's going to deliver it and who's best placed to deliver it. Because we may be very good at observational medicine, but some of that is we've defaulted to being good at it. because other people are less good at it or don't want to pick it up at all, when actually they might do aspects of it better. And they might mean that the patient didn't have a second observation visit, or you need to come back again for an outpatient test or whatever it is. So I think there needs to be some transparency about the decisions about those kind of satellite activities that's based on what does the population need. And that involves there being some respect about commissioning. And I don't know how healthcare is commissioned as such in Australia. But in the UK, we've now got a new system where you've got something called an integrated care board or integrated care system, and it should be taking, and it's the point of it, is that it should be taking decisions about what provision of healthcare there is, depending on what is needed. And what is needed in South London may be very different from what is needed in Chelmsford or Oxford or wherever, and we get that. But it needs to be transparent, and so that the right people are doing what they should be doing, and it's not just based on passion or disinterest.
Thanks, Will. Good question. Actually, it's quite timely because I think emergency medicine is going through a bit of growing pains at the moment. We are, by nature, we're the people that go, if there's a problem, we'll just lean in and solve it. And in some ways, I think we've been almost a victim of our own success in that way. It's a conversation I think we need to have as a specialty. What's in our lane? What do we actually do? How do we add value to the system? But in a way that's not becoming the full inpatient team or the full proceduralist. So how we get into that and how we have that discussion is what we'll be doing probably the next 12 to 18 months, is try to really start thinking about who we are as a specialty, what it is that we do, and also sometimes what is it we actually shouldn't be doing and we should hand off. As an example of this, I worked as a GP for a couple of years. I have some understanding of what they do. I won't say I'm really good at it, but I've got some idea. But I can tell you emergency physicians are not good GPs. We do not have that skill set and we don't do it well. So trying to step in and fill a gap in another specialty's field, although it may be a good temporising measure, it is providing care to the patient that they need, we're not probably doing as well as the other group do. That's why they exist. So where we add value, I think we need to invest a little bit more in, but I think there's only so much of the pie, isn't there? And you've got to split it up. Where is it so we can actually start to rein back a little bit, because that's not our space. And that's the tough bit.
Just to add to that, I'm going to make a plea for keeping minor injuries as part of our skill set. And the reason for this is that actually the litigation attached to that, by not having people who are appropriately trained, is increasingly a concern in this country.
Thank you. When it comes to advances in healthcare, where do you see the major benefits in emergency medicine from the advent of artificial intelligence, telehealth, all these adjunctive sort of technologically based assistance? How is that going to help us, and where are the risks associated with that for us as a specialty over the next 5 to 10 years?
So let's take a step back from AI, which is this new buzzword. Let's just take a big step back, just going back. What has been the impact of the internet and how that needs to change what we do? So I qualified in 1994 before the internet, and I had a little book in my white coat pocket, the Oxford Handbook of Clinical Medicine.
Yellow.
My head was stuffed full of facts, protocols, algorithms. I was a walking medical library. And the whole way we do everything at that point, you were just supposed to know stuff. And if you didn't know stuff, you had to go and look it up, and it was really difficult. And the formulary would be locked into the nurse's cabinet as a sort of power play. And we're in a different world now, because that information is all around. But how do we train and examine people? We put them through a memory test. I think we're in a situation now where a good doctor isn't the person who goes, I know the answer to this, it's bang, like that. A good doctor for most things is, I'm not sure, I will go and look it up. You all probably go and look up drug doses. Apart from the very, very super critical stuff that you're doing, all the stuff you're doing every day, you need to be looking stuff up. And that's got huge implications for the way we're doing stuff. And our patients know more stuff. And sometimes they've got more misinformation. So our job now, we're not medical libraries, we're medical librarians. And we need to guide our patients and get better at explaining to our patients that they don't have POTS or fibromyalgia. Actually, they may actually have something quite serious. But we need to actually get it better at navigating patients and guiding them through digital health. And digital health is going to create further inequalities. The concept of digital exclusion is coming down the road really fast. When I phone my mum and FaceTime her, I spend a lot of time looking at her ear, you know? We've all been there, but the people in this room will be really good at getting their health needs initially answered by something on their phone, but there's going to be marginalised communities, old, mentally ill, people living in all sorts of different environments who are going to find it really hard to get that level of access. And we need to think about digital access as a problem for our patients.
Just on that, I just wanted to, I think the conference theme so far, when I was sort of watching this morning's presentations, one of the things that I pulled out is something that I really try to teach my registrars. What we're trying to do is create a body of expertise, not people that are competent in it. We want experts. And if you look at how people train or your mental concepts of competence and unconscious competence and that really thing up to being an expert. When you're doing resuscitation, we start with the algorithms, and you have to know them. You just have to know it. But there's a point after that where you also have to be able to step off the rails and get better. The argument's the same as a checklist. If you take a checklist with a poorly performing team or a novice, it will bring them up to a level of safety. So checklists are very useful to that point. But what they will do for an expert team is it can actually drag an expert team down too. So there is a balance of that as well. Just a quick side tangent. They did a good research study looking at this using fighter pilots. And I like to think of us as fighter pilots. We're academically quick, and away we go, and we're under time pressure to do it. They took two teams. One team was instructed to follow the rules. The other team was go Maverick. It's pretty easy to know who won the war games. It was a Maverick team. If you get a body of experts and you put them through and let them do what they do, naturally, they will perform at a higher level than if they're constrained by the checklist. So I think that came out through this morning's list. And I think that's all of us, what we're trying to do is really create that expert body, and then that's where we add value to the system. And educating our people who are trying to come up with that, and misinterpreting things is also useful.
So I think we're going to have better data, and if we don't get better data, it's our own fault, but we really must get better data. I suppose one of the ways we've always thought about emergency medicine people is that we make decisions based on minimal information at times. Well, actually, there'll be less reason to have minimal information. For our patient records should, in the future, be much more accessible to themselves and to us. And so we shouldn't make mistakes of not knowing what was going on in the patient. You hope that the records will be in some way summarizable, that you won't have to be ploughing your way through endless screens, but it should be that we know more about our patients when we're treating them, which will be unusual. We then hope that we will have more information about them generally as a group, because emergency medicine has not been great at knowing who we treat. We've struggled with getting diagnostic codes accurately and actually knowing our case mix. We've struggled with understanding acuity and how much effort we need to put in to manage cases. That has been incredibly damaging from understanding funding point of view, because we've never been able to say what is it we actually do that requires this funding, and how across departments, across countries, do we say whether this is a value for money system or this is a very efficient system. So we ought, with new technologies, be able to have better data which will make planning healthcare better, will make individual care better and give us the opportunity to do individual care better, and help us to deal with the volume. We generate so many pieces of information about patients, and anybody who's on duty doing the checking results or checking x-rays or whatever it is, dealing with that kind of volume is very, very hard to do it well. And you can't help but feel that somewhere along the line there will be technology that will help us. We've been doing an interesting AI project with CT brain scans, and actually the advantage is not finding the normals. Technology is looking at scans find it quite difficult to say something's normal because humans are infinitely variable. And the chances are we're going to get a lot more information about how variable humans are. But what they are good at is pinpointing that there's something weird. And therefore focus on the weird ones so that you can start managing those cases. So dealing with the volume of information that comes into us, one would hope technology is going to do. I have got a clinical director at the moment who's completely obsessed with voice recognition software. Dragon this, dragon that, it's just everything's dragon. But yes, that's a really interesting technology. But how do we use it in an open plan, noisy emergency department? You know, a lot of these people think about these technologies in relation to the one-to-one in an office doing consultation. So how do we start getting technology that works for the patient privacy? If you're sitting there dictating your notes in an open plan and somebody's listening next door, how are we going to deal with that? But it seems solvable. So I think there will be volume of data advantages to how to deal with it and how to then get information about what it is we actually do. And I really, really hope that we get good data that we can say, this is what we're adding to the health system. And we don't lose information along the way, which seems such a waste.
And now, focusing down on telehealth, it's certainly been a popular evolution during the time when we couldn't see patients face-to-face as well. But it seems to then been adopted as a bit of a time saver, a way to access healthcare where there's limited resource, etc. What do you see as the dangers and benefits of telehealth in the undifferentiated emergency patient?
You only get half the story. I mean, there are times when it's incredibly useful. And I can remember doing stroke thrombolysis where I was doing it as telehealth. I was looking at the patient from my bedroom, watching them on the trolley. And you could pick up enormous amounts of information, actually. It was easier seeing almost what was wrong with them than when somebody was examining them. So that you can pick up subtle stuff. But you're right, it's being introduced as though this is going to save personnel, save time. It's not. You need to have people to do it. It's not just an extra you can add on. You need to have the ability to know when actually it's not enough and have an offering. And you also need to know that patients don't always tell you everything. They don't always mention and they don't always point, you don't get they smell of alcohol or they're looking shifty and they've got bruises and this is domestic violence that you're not picking up and they can't tell you because there's someone else in the room. So we've got to know we've got to use it to all its advantages, but there are real risks if it's if at heart of it, people are doing it to save money, it's not going to work.
I would agree with that very much, but I think what you've got to realise is what you're doing with this is creating another channel.
Yeah.
You're not substituting a channel, you're creating another channel, and for that's work that needs to be recognised, planned for, resourced, with the infrastructure around it. It's very mixed. I think there are some places where it would be very helpful, particularly around, so we've run, even before the pandemic, in our region, which is a big geographically dispersed region, a really good form of telemedicine for burns. We send the picture to the burns thing, and the effect of this is we've stopped transferring lots of people in the middle of the night, and it's all planned, and it's more efficient, and it's actually better patient-centered stuff during the day. So simple stuff like that can be beneficial, but it's a new channel. And the way the world works is every time you create a new channel, you don't close another channel down, you create extra work. And there is an element of supply-induced demand for this. People will expect it, and then you'll get a bit of telehealth, and then they'll come up to the department, and then they'll come to another thing, and then they'll have another tele-department. And people value simplicity, so it needs to be thought through properly.
Yeah, I think you covered everything. And it's such a broad term, telehealth, and it covers so many different aspects, and some of it we've been doing for decades, when we're providing telephone or telephone advice to other doctors that phone in, we've been doing it for a long period of time. I think there are areas where it works incredibly well and there's a definite role for it. I do worry about, particularly non-specific abdominal pain when people are trying to give advice for that sort of stuff over telehealth. I think there's probably some issues that will come out of that. So it's a worthwhile thing. It's worth investing in. The thing that always makes me think is that telehealth is not going to stop the access block. You could probably reduce the number of people coming through the waiting room, but the people that need a bed are still going to need a bed, whether they've been seen by the telehealth or not. And maybe there's just creating an extra step, another level of service that's unnecessary in the whole system and making it more complex. So for me, it's a bit of a mixed bag.
A thing that I find quite interesting is when I went to renew my medical indemnity, they've actually added the question, do you intend to practice telehealth? Which suggests they're going to recognise it faster than most government organisations, and there'll be a punitive aspect to it from an indemnity perspective. All right, now I think we have a moment for a question from the audience. Does anyone have any pressing pressing questions for our esteemed group? Oh, there's one. Look, Middleton, Junior.
Use that. There it is. Oh, there it is. Oh, that bit. Thanks. Hi, thanks everybody. That was excellent. I wanted just to explore a little bit more the question of data and what you do with it and new bits of the health service and stuff like that. I think the figures show that the amount of data in the world is going to actually double between 2022 and 2025. So the entirety of data will double. Of that, 30% is health data, and it's growing. So when you talk about ED avoidance or monitoring at home or sensors or all of that sort of business, which everybody is, and every commercial company is trying to get in on the act, what you're talking about is a huge flood of data that possibly could be really useful in preventing people getting sick, and potentially could be very useful in monitoring people when they leave. But the point is, I think you have to invent a new bit of the health service to deal with it, however irritating and difficult that may be, because nobody else is there to do the job. You know, GPs don't want to know. People have talked about, oh, well, you just stream it straight into the electronic medical record. Who's going to look at it? Who cares? Because the answer is nobody at the moment. So if you've got that much data which could be really useful, what are you going to do with it?
And I would imagine that you've spent part of your life writing a discharge summary from critical care, which is often a massive data dump. I think actually the solution about this is we need to encourage patients to own their own data better. And I think we need to get away from this parochial thing that we're holding the data. There are countries in the world where you own all your health data and you go across to various systems and you log into a computer and you show your physician all the data that's known about you. We need to get people to own their own data. I think that's fundamental to it. And once you do that, and you could have safeguards because there'll be difficulties. Nobody wants to be told by a computer that they've got cancer when they get that CT report. There need to be some safeguards built into this, but generally getting people to own all the stuff, and that brings us back to that whole point of digital navigators, navigating people through all the information they hold about them. I think you're right. I think, forget AI, actually some sort of program that scours this and produces a problem list which is easy to understand will probably do more good than any predictive analytics.
So we have a real problem in the UK that people set up pilots of things and they plan to collect data, but they have no plan to who's actually going to look at the data, that there's going to be an endpoint, and that there's going to be a conclusion from the data. They just collect the data. Someone will produce a rather half-assed paper on it, and the pilot will continue with no proof that whatever the pilot was for had any benefit, and I'm afraid NHS 111 has been a stellar example of that gets set up as a system for one thing, morphs into a system as a pilot for another thing, and there's masses of data. No one is actually looking at it, and nobody is acting on it. So I would agree. I think healthcare has to start having a little bit of rigor about what they're collecting. So if you're going to set up a remote monitoring of SATs, there has to be an algorithm that says what you're going to do when and if. And there has to be trigger points to bail out, and there has to be a decision as to whether at the end of whenever you've made a valuable contribution to that person's individual healthcare and to healthcare in general. So, and in a sense, we're sort of responsible for this. We engage in these things often and don't don't do the hard work. But I agree, we need to have analysts. So at the minute, my extremely large division, which is about the size of 2 district general hospitals, has something called the engine room, which is our data people. We normally have 3 people in it, and we're now down to 1. And everyone kind of thinks that's okay. You know, we're in a bit of a financial crisis, so we'll just carry on like that. That's crazy. We've got huge amounts of data coming in, and we won't be able to make the most of it. And we won't make good decisions, and we certainly won't make better decisions. So I would support, we need analysts within healthcare to have a status, and it's not necessarily research. It is what it is. It's not just about research. It's about actually mining data for what it can tell us about how we should be making decisions about healthcare. I'm not feeling desperately hopeful about that.
Your question made me think of wearables, actually. That's where I went in my head. Because one of the things that drove me spare as a GP was the bloody home BP monitoring. You know those things? How many times have they come in, my blood pressure's 220, I get it. And they come in evening, and they're really anxious about it. And the more that they get anxious about it, the more the blood pressure goes up, and it makes this horrible cycle. And I can just sort of see, that was supposed to save work. It was supposed to save people coming back to the ED, and it actually, or back to you as a GP. But it had exactly the opposite effect. So wearables may or may not help things. They may make things a bit worse, actually, unless we also put into it, and this is where I think AI has a real role. So it needs to be supported. So if you've got a wearable that's looking for AF or a blood pressure monitor, that it actually tells and educates the patient what to do next, and bring them in when there truly is a need to do it, not just because it's setting an alarm off. Like a lot of things, it sounds good on the outside, but without the really sophisticated, nuanced thing that sits underneath it can actually lead to problems.
Thank you very much. So my final question, we're all probably of a similar vintage. I'd like to take you back to the 1990s, a time which is probably blurry for many of us. Malcolm? If you had the opportunity to turn around to your 24, 25-year-old self, leaving medical school, taking a career through medicine, what advice would you give?
I would actually say it's going to be fine. And actually, first of all, you can't plan too much. So the job that I'm doing now is very different to the job that I first did in my first emergency medicine post. I was part of 10 doctors working in Portsmouth, all SHOs, all wearing our stripy shirts with our cufflinks and our white coats and our little Oxford Handbook of Clinical Medicine, with no real clue what we were doing, with one supervising consultant who spent his time in the office writing a rota, answering complaints, and then trying to find people to replace us. That was his job. I now work in a department that sees about the same number of patients. We have 35 consultants. In total, we have about 70 juniors. The capability, the diagnostics that we're providing. In my first year, I organised 1 CT scan. 7% of my patients going into my department have a CT scan now. We are doing very different medicine. So my first advice was, you can't really plan that much. Medicine is about opportunity, and things will change as you go along. The one regret is that apart from buying shares in Apple, is that I didn't learn to code. That would be the one thing, actually spending time and getting really good at informatics, because I think that's going to be a useful transferable skill in every branch of healthcare.
Really? Gosh, you're fun at parties.
I caught COVID at Catherine's party at Christmas.
I qualified in 94 as well. If I was going to go back then, I agree with you. Like, what we're doing now is completely different to what we did then. And I think in 10 years' time, we'll be doing something completely different again. And I just think that's super exciting. I think that's just the best thing to do. So what would I tell myself at 25? I'd say, go and have more fun. never say no to a party. And I'd also probably tell myself that blues...
Unless it's Catherine's Christmas party.
Well, yeah. COVID wasn't
We
it?
still had fun. It's just the day after it was a bit awkward.
And that the Blues are going to win the State of Origin, and they'll have it actually... that's better than investing in Apple.
Okay, so I feel slightly awkward about this question because I think that the 25-year-old me in 1990s, I don't think I was 25 then, but yeah, I would say yes, your career is going to be fine, you're going to have a great time, it's going to be really incredibly interesting, emergency medicine's fabulous. I don't regret for a minute doing that career. I think a 25-year-old now, and particularly in the UK, is really struggling with looking at what the future in medicine is. You know, they're burdened with debt. I had a daughter of a friend of mine staying last night who was going for a job interview today, and you know, she's not a doctor, but she's got 40k of debt in her student loan thing. She views this as a tax rather than a debt, which I think is a good emotional way of looking at it, actually. But you know, we've got a generation of people who are in an uncertain world with medicine, which is very challenging. You know, litigation, etc. It's all getting messier and more difficult, and they've got this extraordinary debt, many of them, and they've got a health system that's looking difficult, and trying to keep them believing that they're going to have a really interesting career, because there's nothing that isn't as interesting as doing medicine. And you're not going to make huge amounts of money, but you are going to be stimulated all the time. And emergency medicine absolutely has it at its heart, has the ability to be interesting and valuable and contributory and have amazing opportunities, and you can branch off into bits of it, and you will have a fabulously good career if you can get yourself over those real worries that people have got at the moment. But yeah, be a hang on in there and stick with it.
All right. Well, thank you all for listening. Thank you very much to our panel for the discussion. I'd like you all to put your hands together and thank you for your contribution.